Fantastic. So the webinar is beginning. Let me just bring up my participants list so we can see people making their way in. It's funny, I say making their way in. It's a digital, I guess a digital form of making your way into a room for a webinar. But I can see people are making their way in, which is great. Okay, so hello, everybody, and welcome to today's webinar. I'm Nathan from the European Pain Federation, and today we'll be exploring how traumatic experiences, starting from childhood adverse events to adult PTSD, impact brain functioning and pain-related disability. I'm delighted to be joined by Kevin Voles and Gillian Miller, who you might be able to see on your screen. And we will have introductions and a welcome from those in the next couple of minutes or so. Thank you both, of course, for joining. But first, I would like you, or like to let you, the audience, know how today's webinar is going to work. There's, like all of the webinars that we host here at EFIC, a Q&A function, which you can use to ask questions throughout the webinar. No need to wait until the end. Feel free to get those straight into the Q&A function, and we will ask our panelists your questions a little bit later on towards the end, where we can have a good discussion. There's also a chat function, which is a nice place for general comments, any other kind of thoughts which might not be a question. Speaking of which, we love hearing where all of you are joining us from during our webinars. So please let us know. Type your city, your country into the chat to let us know where you're watching from today. Or even how about letting us know your profession, your discipline, your speciality. That would be really useful for our speakers today. So let us know where you're watching from. It's also worth mentioning that this is, of course, a recorded webinar and will be available to watch at a later date on YouTube and the EFIC Academy platform and all the other media outlets that we use. I can see a couple of people, I'm assuming, actually. Come on, people, let's get the countries and everything in the chat. Let us know where you're watching from. It'd be really, really useful. Helps us contextualize our thoughts for today. Okay, so I think that's enough from me just to get started. Let's hand over to our panelists today for a short introduction and get to know them a little bit better. Kevin, Gillian, sorry, not Julian. Thank you so much for joining us. Gillian, please tell us a little bit about yourself. Welcome.
Thanks, Nathan. It's a pleasure to be here. I'm Gillian Miller. I'm an associate professor at the University of Calgary. I'm a neuroscientist by training, but I'm actually in the Department of Anesthesia at the university. And my PhD was largely focused on acute pain in premature babies. And I didn't start in chronic pain in youth until my postdoctoral training, and then found my real passion there and have been in that area ever since, and particularly interested in how trauma might be underlying the development of chronic pain in youth. And that's been the primary focus of my research since starting my position in only 2019, actually. So it hasn't been too long. So really excited to be here and to share with all of you what we've been working on in Calgary.
Amazing. Thank you so much for joining us. At what time this morning is it for you?
It is currently 4:30 in the morning.
So it's extra strong coffee this morning. So thank you. So we'll go easy on the questions for you this morning, at least until we get a bit along the line. Just before we have Kevin introduce himself, I can see that the chat function has had a few issues this morning. We will go ahead and try and resolve those. So apologies for the chat function. I was a bit surprised that nobody was letting us know I thought we were all being super secretive today, that we're not letting everybody know where we're watching from, but we will try and get everything working. I can see some Belfast and things coming in now. Great. So let us know where you're watching from. Apologies for the issues. Good morning, Kevin. How are you doing?
Good morning. Thanks, Nathan, for the introduction and the invitation. Good morning, everyone, and thanks for attending this webinar. My name is Kevin Voles. I'm a clinical psychologist by training. I'm a professor at Queen's University in Belfast, and I also work clinically at our city's secondary care pain service, which is the Belfast Centre for Pain Rehabilitation. I've been working in chronic pain for about 30 years, I think. I sometimes joke it's the only area I know much of anything about. So it's a real pleasure to be here today. And again, I'm looking forward to the webinar. Thank you.
Fantastic. And it's great to have you. Thank you so much. Long time, very, very experienced. So thank you so much for being here. I can see lots of people, Athens, Greece, Portugal, Sweden, Norway, Belfast, of course, at the start, Belgium, France, Channel Islands. Thank you all so much for joining us today. It's great to see everybody joining. A very, again, quick reminder, questions into the Q&A function if you can. This is a fantastic opportunity to ask directly to our presenters today. And we will, of course, ask those a little bit later on. So let's begin, I think. I'm going to hand you over to Gillian, our first presenter, if you want to go ahead and share your slides. Thank you so much for being with us.
Okay, thank you. I'm just gonna get these started here. Okay, everyone can see my screen okay?
Absolutely, thank you.
Wonderful. Okay, well, as I mentioned, I'm extremely excited to be here with you all today to present our paper entitled Adverse Childhood Experiences, Brain Efficiency, and the Development of Pain Symptoms in Youth. I just want to take the opportunity to acknowledge my former master's student, Samantha Miller, who led this work. It was actually her undergraduate honors thesis, and that she saw through to publication. And now Samantha's currently at the University of Limerick studying to complete her MD. So hopefully one day she'll become a proliferative clinician scientist. And then I would be remiss not to shout out Karen Kobos, who I realized also joined us here in Calgary at 4:30 in the morning. Karen Kobos is the second author on this paper, and she is the lead in brain efficiency in my lab. So if any sort of real topical questions come on brain efficiency, hopefully she'll pop on and answer them for us. So stick around, Karen, to the question period. You are definitely the expert on that. So, oh, and Karen is doing her MD PhD here in Calgary. I'm very lucky to have phenomenal trainees to work with in the lab. So jumping right in, our lab is really interested in what's called adverse childhood experiences, or as I'll refer to throughout the rest of this talk as ACEs. So ACEs are stressful and traumatic events that are experienced prior to the age of 18, and they can be classified into three categories: abuse, neglect, and household dysfunction. And approximately 49.8% of youth report greater than one adverse childhood experience in the course of their life. So there's been plenty of research now to demonstrate there is actually a dose-dependent relationship between the number of ACEs and the risk of developing a mental health or chronic health condition. And this would include the development of chronic pain. Recent studies have shown that individuals who have 4 or more ACEs actually have a 2.7 time higher risk in developing chronic pain in their lifetime. Not surprisingly then, it's been found that youth with chronic pain also disproportionately report a higher history of ACEs as compared to youth without chronic pain. And with ACEs can also co-occur post-traumatic stress symptoms. And so post-traumatic stress symptoms are a symptom level response to trauma exposure that include hyperarousal, re-experiencing, avoidance behaviors, and youth with chronic pain have reported clinically elevated levels of PTSS, at which case it could be considered PTSD if prolonged and severe. And they report this at a rate of 32% as compared to only 8% of healthy controls. PTSS is slightly different in that it can develop in the absence of a life-threatening trauma, where a life-threatening trauma has to be present for it to be classified as PTSD. So for the rest of the project going forward, we'll be focusing on ACEs and PTSS as opposed to a full-blown post-traumatic stress disorder. A bidirectional relationship has been proposed between PTSS and chronic pain, where concurrent PTSS and pain have been associated with reports of more intense pain and increased sensitivity to noxious stimuli than either condition on its own. And a main purpose of my research has been trying to understand better this bidirectional relationship between pediatric chronic pain and internalizing mental health conditions, such as post-traumatic stress symptoms. And so back in 2016, when I was in my postdoc with Dr. Melanie Knoll and Dr. Nivez Razek, we put together this model proposing the different factors that might be underlying this bidirectional relationship. And the focus of my research going forward has really been to try to understand this neural component that might underlie this mutual maintenance model. And so that brings us forward to our current study. This was actually the first study that I started my lab, the PAINS lab, in 2019, my first funded project. So very excited about it. It's entitled Pain in Youth Exposed to Traumatic Experiences, or AKA the PAINT study. And for this study, we recruited 50 healthy youth from the community between the ages of 14 and 18 years. And we plan to see them 2 times, one time, which we refer to as baseline, and then we followed them again 3 months later. And at both visits, they did the exact same thing. They would fill out a questionnaire asking about their pain and mental health background. And then they underwent sensory testing to look at their responses to light touch, warm, cold, heat, and pressure. And then we also had them complete an MRI. It was about 30 minutes, and we obtained both structural and functional MRI data. And we did this both, again, at baseline and follow-up so that we could look at the change in these variables over time. So in order to look at ACEs, we administered the Center for Youth Wellness Adverse Childhood Questionnaire, or the ACE-Q for short. And this was a clinical screening tool that calculates the cumulative exposure to ACEs in patients ages 0 to 19. This instrument has 2 sections. So it has the traditional 10 ACEs that have been linked to population level data for disease risk in adults. And so this includes questions like your child's parents or guardians were separated or divorced, your child lived with a household member who served time in jail or prison. But the ACE-Q also includes an additional 9 items that have been identified by experts and community stakeholders. And so some of these 9 items that are outside of the traditional ACEs include your child was in foster care, your child experienced harassment or bullying at school, your child was separated from his or her primary caregiver through the deportation or immigration, and so forth. And so you'll notice in this chart here where we're describing the ACEs in our paint population, it's actually quite high for the number that experienced 4 or more ACEs. And that's because our ACE questionnaire was totaled out of 19, not the traditional 10. But it is notable that of the 50 kids in our study, only 12% had 0 ACEs at all. In addition to the ACE-Q questionnaire, we also had them fill out the Child PTSD Symptom Scale, or the CPSS-5. This is a 20-item scale that maps onto the DSM-5, where youth identify their most stressful experience and then use the 20 items to self-report their resulting symptomology related to this experience. And then shown here, I have the 5 most reported traumas by our group, such that 18% at baseline felt unsupported, unloved, or unprotected by their family. Approximately 16% were concerned with the health and well-being of a family member or friend. 11% were abused or assaulted by a close family member, friend, or romantic partner. 9% promoted the death of a relative or friend, and then a small portion had identified marital conflicts within the household. And there were other traumas reported by the youth as well. These are just the top 5 most common ones reported by the group. Okay, as mentioned, at both time points, the youth also underwent an MRI, and one of the sequences obtained was a resting state functional MRI. So looks at the brain's activity just while it's at rest. And there's a number of different ways to analyze resting state functional MRI, but what we applied was called graph theory. And this is the mathematical relationship between different nodes or brain regions in a brain network. And there are many graph theory metrics that we can use to assess the brain. But for this project, we were primarily interested in global and local brain efficiency. So before I jump in and explain the difference between global and local brain efficiency, we need to define what exactly we mean by efficiency. So when we talk about whole brain efficiency, we are referring to how information is transferred across the neural network. As such, brain efficiency has been implicated in information processing and cognition, where lower efficiency is linked to poor information processing and deficits in cognition. At the bottom of this slide, I have a very simplistic diagram to help better understand what this means. So let's say the yellow dot is trying to communicate information to the pink dot. A less efficient network would transfer this information through several other dots before reaching the red dot. Contrastingly, an efficient network would transfer this information in a more direct way. And a great analogy to this would be the game Telephone, which most of us would have played at some point during our childhood, where the message gets passed along across multiple people. When it happens this way, it not only takes longer for the final person to receive the message, but oftentimes that message is distorted by the time it gets to the last person. In our brains, each dot would represent a different brain region. And with this understanding, we can now describe the difference between global and local efficiency. So global efficiency refers to long-range communication between one region and all the other regions in a neural network, regardless of their physical proximity. So we can calculate global efficiency in each region in this network. So in this study, we segmented the brain into 90 different regions. And then the efficiency of each network is the mean efficiency of all the regions in that network. Further, global efficiency has been linked to information integration. In contrast, local efficiency refers to short-range information transfer between neighboring brain regions. Similarly to global efficiency, we calculate the local efficiency of each region in the network, and then the efficiency of the entire brain is the mean local efficiency of all the regions in the network. And local efficiency has been linked to information segregation. Finally, in addition to the brain imaging, as I mentioned before, we also did some pain metrics with the kids. We asked the kids to report their pain intensity, which is the most commonly used pain scale among youth and adults. And this is just a numerical rating scale where they report their pain from 0, no pain at all, to 10, worst pain possible. And then we also obtained measures of their pain sensitivity using quantitative sensory testing. And to do this, we used von Frey fibers to look at their mechanical touch sensitivity. And we also used the Q-Sense MEDOX system to look at thermal responses to cold, warm, and heat. All right, and with that, I can finally get to what our hypothesis is. In this study, we were trying to determine whether higher exposure to ACEs will be associated with greater pain intensity and sensitivity to noxious stimuli in youth with lower brain efficiency. And so what did we find? Here in this table, we were demonstrating that a greater number of ACEs was significantly associated with lower global and local brain efficiency. And this is even after controlling for age, gender, pubertal status, and their other PTSD symptoms. And then we found a moderation between greater ACEs and higher pain intensity that was moderated by brain efficiency. So if you look at this graph that we have here, we have one graph for we have Yes, one graph for global efficiency and one graph for local efficiency. And each display similar relationships with self-reported pain intensity that's on the y-axis and the number of ACEs that's along the x-axis. And just trying to get my little thing out of the way because I'm not sure if it's blocking for you. Okay, here we go. So what this graph shows is that for youth who have lower brain efficiencies, they report greater pain intensity with the higher exposure to ACEs. Now, we found somewhat the opposite effect from pain intensity when we started looking at sensitivity, such that there was moderations found, but they were in the opposite direction. So youth with lower brain efficiency tended to have decreased sensitivities to mechanical detection and also warm and heat detection. But I should note, when you look at these graphs, only the heat threshold survived correction for multiple comparisons. So we need to consider or look at the mechanical detection and warm detection thresholds cautiously. But with the heat detection threshold, we do see that the youth with greater exposure to ACEs had less sensitivity to heat pain with lower brain efficiency. So we went to the literature to try and understand why this might be the case. And one thing that we find in the literature is that ACEs can lead to persistent neuroactivation, which may then lead to excitotoxicity. So there's a large body of stress literature that demonstrates that increased stress during early childhood can actually age the brain faster. And this might lead to the early death of some cell neurons. And also, this could also lead to significant alterations in nociceptive processing. And again, from the literature, we know that as an individual is transitioning from acute to chronic pain, we see a significant change in the processing areas of their brain and how pain is being processed. So it moves from a primarily somatosensory experience to a much more emotional experience, engaging the thalamus and the hippocampus involved in like memory formation and also the amygdala and the prefrontal cortex and engaging those fear networks. And so as the brain, the ACEs is changing, the connectivity and processing, we do see, as we found in this study, that greater exposure to ACEs was associated with lower whole brain efficiency. And that the lower brain efficiency after trauma exposure can lead to more difficulty in processing pain information and have decreased pain sensitivity. And this was something, the decreased pain sensitivity is actually something we had identified before in another study led by a former medical resident in anesthesia, where he looked at the relationship between trauma and pain sensitization in youth with chronic pain. And we found that in youth with chronic pain, there was a similar relationship where individuals exposed to higher trauma actually demonstrated less sensitivity to thermal testing. And so it's interesting that in this population now without chronic pain, that over time we see a similar chronic pain phenotype, which may suggest that these individuals who have high trauma, low brain efficiency, and decreased pain sensitivity may actually be a signature of risk for developing chronic pain in the long term. And then with the lower brain efficiency after trauma, we see difficulties with pain inhibition. So again, this can be talking about the difficulties in silencing those fear networks and inability to downregulate the pain signals. And this may be why we see high reports of pain intensity in this population. And again, this is comparable to what we find when we look at the chronic pain population, which would suggest that we might be identifying a particular chronic pain phenotype and that these youth may be at greater risk for developing chronic pain in the long term. So there were some definite limitations to this study I want to address before I hand it over to our other speaker. And that is that the ACE-Q is a clinical scale. And so it's not actually meant for research use, which means that it doesn't have reliability or validity. And it was a simple cumulative score that was obtained. So the youth just identified how many of the 19 ACEs that they were exposed to. They did not indicate on that questionnaire the type of ACEs that they were exposed to, the frequency and length of that exposure, um, or when the exposures occurred either. And so this is a very simplistic picture overall of the ACE exposure in youth, and doesn't give us some of the more nuanced detail to help us understand better the relationships between ACEs and brain development and pain. This study was also very small, as noted here. It was designed to be a pilot for future work. So with a sample size of 50, we were limited in some of these more detailed, nuanced analysis that we could do as well. Also, the time sample was very limited. We saw these youth twice over a 3-month period. A 3-month was chosen because that is the length of time for pain to be considered chronic. So technically, a child in this study could develop chronic pain over the course of the study, but that really wasn't what we observed. And realistically, we would need to follow them over a much longer time period to really understand better, like if the trauma they experienced is a true driver of the development of chronic pain in these youth. And so luckily, the data that we did find was promising enough that our group received a Canadian Institutes for Health Research Award to really go to this next step so that we can get some of these additional details. So from our PAINT study, we are now running PAINTED, which is looking at pain in youth exposed to traumatic experiences. And in this study, we'll be recruiting youth from the community who are between the ages of 12 to 18 years. And very similarly to the PAINT study, they will come to the Alberta Children's Hospital and they'll fill out a questionnaire, they'll undergo sensory testing and get an MRI. But this time, they will do this every year for 4 years. So we'll get a much longer picture of how their pain symptomology changes over time and whether or not their traumatic experiences are a true driver of that. And we also have used a different ACEs questionnaire this time that'll give us some of those more intricate details that we were missing from the first study. So I'm extremely excited about this. We've been running it for about a year now, already have about 120 kids in the sample. Unfortunately, I don't have new data to share with you today because we are just doing everything we can to get all of the data collected and starting to get analyzed, but maybe you'll have to come and have us back again so we can share the next iteration of this story. So I will pause here, but just want to take a quick second to, again, thank Samantha Miller, who led this paper, Karen Kobos, who is on the call today, who has really led the brain efficiency portion of this project, and all my other collaborators on this study, as well as our funding sources that made this research possible. Thank you for your attention, and I'm excited to hear the rest of the speakers and answer your questions later.
Thank you, Gillian. That's really interesting. Thank you so much for sharing that so eloquently before the sun rises at such an early time. Plenty of time to recover now. Thank you so much for sharing that. There's been a few really interesting questions in the chat as well. I think it might be worth, of course, bringing these up towards the end of the webinar, but Gillian, perhaps you can have a read through of those questions and see if there's anything that you can contribute or even perhaps think about ready for the discussion that we have at the end. I think that would be really, really helpful. There's some real valuable questions there. Just a reminder that, of course, everybody can ask questions. You can also, and I didn't mention this at the beginning, but you can also do this anonymously if you wish as well via the Q&A function. You can ask an anonymous question. So feel free to do that if you would prefer. Now, let's hand it over to Kevin for another presentation. Kevin, thank you so much for joining us. Please go ahead and thank you for sharing with us today.
Thanks, Nathan, and thanks, Jillian, for that presentation. As I said during the introductions, I work clinically at our secondary care pain service, the Belfast Center for Pain Rehabilitation. And the data that I'm going to talk about today primarily come out of that work that we do in the Center for Pain Rehab here. And essentially, we were interested as a group of clinicians in addressing a fairly basic pragmatic clinical issue, which is this: what is the relation between traumatic experiences, post-traumatic stress disorder, criteria in terms of diagnostic status, and disruptions in chronic pain-related functioning? And that's what I'm going to talk about today. In addition, if you're looking at the title here, you'll also note in parentheses that these data were collected in Northern Ireland, which is where I currently live. And there is some regional significance to this issue as well that I'll detail in just a few slides' time. We published this paper earlier this year in European Journal of Pain. The citation is there. I think Melinda might link it later because she did it for Jillian. The paper is open access, so it's freely available. If you have any trouble accessing it, feel free to shoot me an email. My email address is at the end of this presentation. I'm happy to send the paper on to you. Before I go any further, I also just want to acknowledge the co-authors on this paper and some of the fantastic colleagues at the Belfast Center for Pain Rehab. Christina Mallett was our doctoral student on this. Jason Brooks is the clinical director of the service. Emma Berry is a colleague of mine at Queen's. Danny Rainey is one of our fantastic nurses. Claire Briggs, one of our fantastic physiotherapists. And Maura McCarran is a PhD student doing some work with us. I couldn't ask for a better group of colleagues, so thank you all. I've already given some of this overview. You know, if you've worked in chronic pain, you'll know there is a sense that trauma and PTSD diagnoses have a degree of frequency in those who have chronic pain. I don't think the literature, or we as a set of clinicians, didn't know that the literature gives very clear guidance on some of the exact nature of this relation. For example, one of the things that we were interested in here is what constitutes the clinically significant risk factor here? Is it about the experience of trauma and that by itself is associated with significant disruptions in functioning in those who have chronic pain? Or is it more the impact of these trauma, at least as represented by ongoing symptoms of PTSD, that is what we ought to be attending to preferentially clinically? And there are models of care and assessment models that kind of prioritize both of these. Some that say this is about the experience of trauma itself, some that it's about ongoing impact and participant responses to these kinds of experiences. And so we've considered in these analyses some of the assessment and treatment implications that derive from these findings. Maybe the best place to begin a discussion of data is just with an overview of prevalence rates of post-traumatic stress disorder out there. What do we know about the frequency of these kinds of diagnoses? There are some large epidemiological studies. These are US-based data, but these studies indicate lifetime prevalence rates of PTSD is between 6 and 7%. A lot of data has been collected in military veterans. There's a large report that was published last year in the UK looking at UK military veterans. And of course, there's a lot of US data. Overall prevalence rates of PTSD in veterans is a little bit higher than out there in the community, ranging from maybe 7 to 9% across these. If we look at individuals who were deployed as part of some of the recent conflicts and wars that these two countries were involved in, those prevalence rates actually increased substantially from 12% to 29%, at least across this range, and are maybe a little bit higher in US veterans. If we look at the data, the prevalence data that we know for chronic pain, 2 review papers were both published the same year in 2017, one by Fishbane et al.'s group and another by Sikvalend and colleagues. And those papers, in summarizing the prevalence literature of chronic pain, suggest that overall prevalence rates of comorbid PTSD and chronic pain are about 10%, maybe a little bit higher, ranging from 9 to 20%. And you can see in that asterisk confidence interval here, the range of between 5 and 17% for some of this. So this gives us a bit of an understanding of maybe what the lay of the land is in terms of PTSD diagnoses out there in various samples across the world. I also mentioned at the outset of this talk that these data were collected in Northern Ireland, which is this bright green northeast corner of the island of Ireland. For those of you who are my age or maybe a little bit older, a little bit younger, I'm 51 years old, you will remember a time when there was a significant amount of decades-long civil conflict in Northern Ireland. Locally, that's referred to as the Troubles. Part of this conflict had to do with community disagreements on whether or not Northern Ireland should be a part of the Republic of Ireland to the south, or whether or not it ought to remain a part of the United Kingdom. As part of the community violence that occurred here, the UK military was deployed into the cities around Northern Ireland, which was associated with a significant increase in kind of overall conflict and violence. So this was a decades-long period of high challenge and high levels of stress here in Northern Ireland. A paper published about 10 years ago indicated that rates of PTSD in Northern Ireland are the highest across Europe. Government report published around the same time, about 10 years ago, suggested the frequency of traumatic events was about 2/3 of the population in Northern Ireland, with a lifetime prevalence rate of PTSD in 9%. So in addition, I meant to start my clock at the beginning of this. Sorry, I'll try and keep an eye on the time. In addition, to this kind of broader implications for maybe chronic pain assessment and treatment, we were interested in understanding a little bit more about our local population, just so that we could do our best to align our services to be useful to those people that we work for. As part of our clinical service, patients fill out a fairly comprehensive battery of self-report measures assessing a variety of aspects of behavioral, psychological, social, and pain-related functioning. We use this information as part of our initial, to inform initial clinical decisions and also triage patients. In addition to that, we ask people coming into our service to consent for us to use their data for research purposes. So this is an informed consent procedure. Historically, over about the 5 years we've been doing this, somewhere around 96 to 98% of participants also consent for their data to be used for research. So for this, we collected data over for this study, we collected data for about a 3-year period between late December 21 or late 2021 and late 2024. And that amounted to just over 1,400 individuals worth of data that we collected. So a nice big sample size here. Demographically, these individuals are kind of probably consistent with other data on there on adult chronic pain services, about 2/3 female in terms of age, generally in the middle age range, with the majority of patients being between 35 and 65 years old. Ethnically, Northern Ireland is inhabited by individuals primarily of white European descent, and you see that represented in our ethnic makeup, in the ethnic makeup of our sample here. In terms of some general pain characteristics, quite prolonged pain duration, most individuals between 2 years and 22 years of chronic pain. And then just as a broad indicator of complexity or pain burden, I've just presented the average number of pain locations that individuals identified. So on average, kind of 3 to 6 pain locations for most of these folks, quite multi-site and high impact chronic pain, as I'll show you in a little bit. In fact, only 8% of this sample identified a single primary pain location. I noted that we ask our patients to complete a battery of self-report questionnaires in order to identify the caseness for PTSD in terms of experience of traumatic events, as well as screening for the presence of post-traumatic stress disorder. We used a screening measure called the Primary Care PTSD Screener for DSM-5. This is published by the good people at the Veterans Healthcare Administration's National Center for PTSD in the United States. This is the same group that's responsible for the PCL measure, a more comprehensive measure of PTSD. Clinically, I think it's fair to say that we have found this to be a pretty useful screener for PTSD. I think we have found it to have good clinical utility. It's a fairly simple measure. It's composed of 6 dichotomous yes/no questions. The first in and of itself, is a screening question. It's a screening item for the experience of trauma. And as you can see here, it says sometimes things happen to people that are unusually or especially frightening, horrible, or traumatic. For example, here's some of the traumatic events that can occur. Individuals are asked, have you experienced this kind of event? Yes, no. If individuals say no, that's the end of the screening questionnaire. If they say yes, a further 5 dichotomous yes/no items are presented, which are the 5 symptoms of PTSD, including re-experience, avoidance, hypervigilance, numbness or interpersonal detachment, and significant guilt or shame. So individuals are asked in the past month, which is the duration criterion for PTSD according to the DSM-5, for what that's worth. Individuals are asked in the past month, have you experienced these things? Scoring for this allows individuals to be categorized with regard to PTSD caseness into one of 3 categories. If individuals note no, they have not experienced a traumatic event, then they can be categorized as no traumatic event. We call that group of individuals the no event group. If individuals say yes and they endorse 3 or fewer symptoms of PTSD over the past month, that is indicative of an experience of a traumatic event, but not meeting screening criteria, at least for PTSD. This cut point of 4 or more has been examined in a couple of studies, and it actually has pretty darn good sensitivity and specificity for a diagnosis of PTSD based on gold standard assessment like structured clinical interview, as well as less robust, less gold standard kinds of assessments like clinical judgment or clinical interview. So that cut point of 4 or higher seems to have reasonably good sensitivity and specificity. The last group are individuals who said yes to an experience of a traumatic event and endorsed 4 or more of these symptoms of PTSD, and those screened positive for the presence of PTSD. And we call that category probable PTSD, as you can see here in front of you. So we were able to divide up our sample of about 1,400, individuals into one of those 3 categories in relation to PTSD. Here's how the overall screening category results came out. About half of the individuals in purple here noted no historic experience of a traumatic event. About a quarter noted experience of event but did not screen positive for PTSD, and about a third screened positive for PTSD. If you're interested in the sample sizes within each of those categories, those are here in front of you now. In terms of measures of functioning, I noted we have quite a comprehensive battery we ask our patients to complete. We assess aspects of pain-related functioning, including like what's here in front of you now, pain interference and social role functioning. We use the National Institutes of Health PROMIS suite of measures in a lot of our data. We also assess pain-related fear and pain-related self-efficacy using the short forms of the pain anxiety symptom scale and the pain self-efficacy questionnaire. We assessed average pain intensity over the past week on that simple 0 to 10 numerical rating scale. And we used 2 measures of depression across this sample because we switched measures about 2/3 of the way through. So the first 2 years of participants completed the PHQ-9, and then we started using more of that PROMIS suite of measures. So we switched to the PROMIS 4-item depression scale. So in just a moment here, I'll show you the overall results of our primary analysis. But I just wanted to reiterate what our primary aim here, our primary research question here was quite simple. Are there differences in pain-related functioning based on PTSD categories? So we've got our measures of functioning here in the vertical column, and across the top are different categories of PTSD. Now, I'm not going to talk a whole lot about the data integrity checks that we did or the methodological details, partially in the interest of time and partially because, in my experience, most folks don't want to hear a talk about that. If you're interested in methodological details, I'm happy to talk about them. In terms of methods, we did a multivariate analysis of covariance. So we examined aspects of our data to identify salient covariates that we wanted to control for in the analyses. Covariates that we controlled for in the MANCOVA were gender, age, number of pain locations. Our primary analytical approach was MANCOVA, followed by Welch's ANCOVAs, followed by Bonferroni corrected pairwise comparisons. In a nutshell, we thought that was a suitably conservative data analytic approach, particularly given our large sample size here. Okay, enough on analyses. Going back to the table at the top, this is a table straight out of the manuscript. You'll see a bunch of numbers here in a moment, which can sometimes be a bit unintelligible. So I'll orient you a bit to these data. First thing that we noticed in these analyses was that regardless of category, there was a high level of pain-related disruption across our sample. For example, you can look at the pain interference and social role functioning here. Scores here are T-scores. So the average score is 50, standard deviation of 10. And so for pain interference, all three groups were more than 2 standard deviations above the mean in terms of pain interference in comparison to the general population. For social role functioning, lower scores are indicative of a worse social functioning. All three groups were close to 2 standard deviations below the mean in social functioning. Pain-related fear, total possible score here is out of 20, so high levels of pain-related fear on average. Of course, high levels of pain intensity, low pain self-efficacy, and quite high levels of depression. So as I said at the outset, this is a treatment-seeking population of individuals, and so perhaps some of this level of disruption is to be expected. Asking you to turn your attention now to the letters here, the superscripts by each number. Superscripts that are the same, so A's in this case, are indicative of non-statistically significant differences in functioning. So I just want to pause here from results for a second and talk a little bit about implications. These data suggest that individuals who have no experience of a historic traumatic event have no differences in terms of levels of functioning from individuals who've had experience of an event but don't meet screening criteria for PTSD. This suggests perhaps at an assessment and intervention level, it's not really about the experience of the trauma itself. Perhaps. Moving over to the other superscript here, the B's for the probable PTSD category, those are indicative of statistically significant pairwise differences. In plain language, what occurred in these results was across every measure of functioning that we included here, functioning was worse in the individuals who screened positive for PTSD. It is sometimes hard to get a sense of the data from looking at means and standard errors. So we also presented something called funnel plots in this analysis. And if you haven't looked at funnel plots before, that's okay. I'll orient you to what they are. In my opinion, it's a great way to see what's happening with your data. Funnel plots tell you this. They tell you a severity score. So in the case of the figure in front of you now, the vertical line is how severe scores were on pain interference, and the width of the funnel tells you about the proportion of individuals who scored at that range. So you can see here for our first two groups, even upon simple visual inspection, there was not significant difference in the makeup of these two funnels. They both look similar on visual inspection. Maybe a few more higher scores here for the event no PTSD group than the no event group, but a significant difference in how that funnel looks for the probable PTSD group, with with absolutely an absence of scores within 1 standard deviation of the mean, and a preponderance of scores quite high, getting close to 3 standard deviations above the mean. In fact, a lot of this sample was at the maximum possible score, suggesting a possible ceiling effect for this. If we look at funnel plots for the other 7 dependent variables we included here, the pattern is the same for 6 out of those 7 variables. Social functioning here, you'll see again, no event and event, no PTSD, quite similar, quite a different distribution for probable PTSD. Same for pain-related fear, same for pain self-efficacy, and the same for our 2 measures of depression. If we were all sitting in a room together, I'd pause for a second to look you all in the eye and say, do you see what I'm talking about here? So imagine that I'm doing that. Hopefully I'm making sense here in what we were seeing in these data. The only variable for which there wasn't a whole lot of difference upon visual inspection was for pain intensity. And if you've worked in chronic pain, you'll know that if we only know pain intensity, it doesn't tell us a whole lot about what's actually happening with individuals. So I think I got about 2 minutes left here, so I'll just move on to conclusions. In conclusion, I've already made this first conclusion. At least in these data, adults presenting for treatment at a chronic pain service, it does not appear to be that the salient characteristic, the salient risk factor for disrupted function, doesn't appear that it's historic experience of trauma. Rather, it appears to be the ongoing experience of disruptions in functioning related to this trauma, ongoing symptoms of PTSD. There are therapeutic models that really emphasize this aspect of pain-related functioning. And one of the primary issues we can concern ourselves with as clinicians is helping people respond better, less problematically to some ongoing troubles. And this pattern of findings is consistent with that kind of theoretical model, that clinical model of approach. Said simply here, perhaps assessment efforts are likely best directed at ongoing experience of disruption and functioning rather than the experience of the event themselves. As we were writing these data up, I came across a paper published by Sofia Ackerblom and colleagues out of Sweden, published in the International Journal of Behavioral Medicine in 2017, where essentially we have replicated their findings. And I didn't know that when we were going into this. So their pattern of results was identical to the pattern of results that we found here. A nice big sample of participants. So we now have 2 papers, about 2,000 patients worth of data that have a similar pattern of findings. I want to talk for just a second about our conclusions in relation to Northern Ireland. If these data are reliable for screening, our rates of probable PTSD are very, very high, quite far in excess of some of the other prevalence rates that we looked at in those other well-developed prevalence studies I've talked about 1 out of every 3 of our patients screening positive for PTSD. That being said, there are a number of caveats to these data. The first is that we used a screening measure to categorize individuals, and it is likely that there's some instability or some error in terms of categorization. The measure itself was based only on dichotomous scores, so it didn't allow us to look at cumulative burden of repeated exposures to trauma, or even things like severity of the individual symptoms themselves. So there's more work that needs to be done here. All of these data were self-report, all cross-sectional, meaning there could be bias, there could be errors, that causal conclusions are impossible to draw from these data. And of course, as I said, Northern Ireland has a very unique history, and so it may be that these data are not generalizable to other regions of the world that have different histories. Last thing for me to do is just show you a picture of the beautiful main building here at Queen's. If you ever find yourself in Belfast, it's worth a walk through that building because it's gorgeous. Highlight that my email address is on the bottom here. I'm very happy to answer questions about these data. And last thing for me to do is just thank you for your time and for your attention. Thank you very much.
Thank you, Kevin. Very interesting stuff. Extremely comprehensive presentations from both of you today. Thank you. Thank you so much for that. And yeah, beautiful building towards the end to finish us on, which is great. Okay, so we have a little bit of time. I love these presentations, lots of information, and a couple of minutes just to go through a few of the questions. Perhaps we can take a step back and maybe not look so much at the differences between the 2 presentations. There's a lot of similarities and they should be considered together as well, especially when trying to translate these skills into clinical practice. But Gillian, maybe we can come to you for sort of the first sort of thought, and I perhaps direct us to Robrecht's point and thought. I don't know if you've had time to have a think about that during the presentation, but Robrecht says, what structural MRI data have you collected, and what is your current aim with that data if you did? Do you think that the structural data could be integrated with your functional findings? And if so, how might that work? What might the benefits be there?
Hi, thank you for that question. And also, I want to apologize, Kevin. I also forgot to start my timer before presenting, and so I'm not sure how long that was. Sorry if I went over. Yeah, just early morning brain fuzz. Anyways, thank you, Robert, for the question. We've collected T1 scans, so we can do volumetrics or cortical thickness measures on that data. We also collected diffusion tensor imaging, so we can look at white matter microstructure measures in this population. And we also collect spectroscopy. I believe it was hippocampal spectroscopy in this study. So a number of, and spectroscopy lets us look at metabolites if you're not familiar with that. So a number of different structural measures have been collected, and we have started to analyze some of that data. We didn't put it together in the same paper because sometimes it's too much, and then sometimes the findings from structure and functional data are not always complementary. So it's a bit extra to have to go and explain the contrast, where sometimes it's higher, structural connectivity but lower functional processing. And so to explain that all in one paper can be a bit much. So I don't have the results from our structural findings in front of me. As I said, we're still working through this data. This was the first publication from this pilot study. And so, yeah, we'd have to see how it integrates, if the story is similar or not. But yeah, I mean, that would be the hope, that it's somewhat matching and reflective and gives us a clinical picture of, identifying a risk in these kids sooner and earlier. I'm not sure per se that, giving everyone an MRI is my recommendation, but I think understanding the mechanisms and these processes is important in order for us to, get more specific and treatments into the future and so forth. So these are some of the goals of the research, and I hope that answered your question.
Yeah, absolutely. No, it's really interesting. Kevin, anything to add on this point?
No, I don't think I'm qualified to add on to that question. We heard from the qualified
that's,
expert.
that's great. Gillian has done a fantastic job there. We hope that answers the question. When we're thinking about, and this kind of popped up a little bit in my head as we were going through in terms of prevalence, it's all really important to understand the prevalence and the impact that this can be having on people's pain experience and the relationship between the two. Kevin, you mentioned, I think in part of the population, 46%, nearly half, had no event or no consideration of a traumatic event. And just thinking about Gillian's mentions of not so much, I quote, sort of full-blown PTSD, but more PTSS. I wonder what influence that PTSS might have in that 46% and whether that might be clinically relevant. And my thoughts come from a clinical practice perspective, in that could it be that we would use these screening tools that you've so eloquently described and not be able to capture those real clinically significant PTSS components, and they kind of go under the radar, and we don't use those to consider how that might be influencing someone's pain? Is that a risk? Should clinicians be looking at more broader impacts of traumatic events in the absence of life-threatening trauma, if that makes sense? Is that something that clinicians should be doing?
It's a hugely complex question, and I can only give an opinion on it based on these data and on the experience we've had. I think that half the participants had no experience of traumatic events that they endorsed. That's one thing, and that is consistent with some of the other Northern Ireland data that 61% report experience of a traumatic event. So at least those aren't the same data, but they're at least complementary. The quarter of individuals who had experience of traumatic event and had a few symptoms of PTSD in this dichotomous item. I mean, I think this is the core of what we found. Those individuals' pain-related functioning was not statistically different. And even if you look at the means and the distributions, didn't appear to be meaningfully different from the group that had no experience of PTSD. And my clinical experience is this, that it's not so much about have people had trauma or not, but how is that trauma impacting their lives in the here and now? If it is because there are lots of ways to respond to trauma. ACEs are really common. Jillian talked about that. It is not a deterministic thing, that if you've got an adverse childhood event, that you are guaranteed to get trouble. And sometimes I worry, as a field, we discuss trauma in a bit of a more deterministic way than I think it deserves, which is if you got a trauma, you're in trouble. I'm paraphrasing there. And what we've got is maybe where our clinical attention might be usefully focused is on the impact of history, on how it's impacting people's ability to live full, free, functional lives in the here and now.
Mm-hmm. Yeah, I think that's a great point. And Jason pops into the chat there that all background events play a role to a pain experience, and it's how we consider those in clinical practice. Gillian, anything to add?
Actually, I do have something I wanted to add. I think what Kevin gets at really speaks to some of the nuance in the data that we found, where it wasn't just a matter of having a high number of ACEs, it was the combination of having high number of ACEs and lower brain efficiency. And those were the ones that were reporting the higher pain intensities in our group. And so it was really that moderating relationship that was significantly impacting their pain responses. So yeah, I think it's not deterministic, as you said, that there is going to be a number of risk factors that combine to create that perfect soup and conditions of which there can be problems occurring.
Yeah, For sure. Thank you so much. And we've had lots of comments and questions, and Peugeot has obviously tipped the hat to the consideration of culture and the complexity that might play in someone's pain experience. Julia there, similar to positive childhood experiences, buffering ACEs. There's a whole complex picture. And unfortunately, we don't have much more time today. Very, very useful stuff. So I'd like to give the floor to our speakers just to summarize kind of the main points that they'd love to get across today. And of course, I'd like to take this chance to thank everybody for engaging in the chat and of course in the questions. But we can come to perhaps Kevin. What would your kind of main points that you'd love to get across today?
So I probably summarized them reasonably well. Perhaps, I mean, there's more. I think we got to continue to look at this. That I think in chronic pain treatments that it's about the impact on functioning, which is the role of clinical services. And then I'll just conclude by saying thanks. It's great to be here. Thank you very much.
Thank you for being involved. And of course, Gillian, which is now 5:30 in the morning, I think, ready for your maybe second or third coffee, I think.
That would be great. Yeah. Yeah, quick summary is I think we're starting to get a picture of what some of the mechanisms underlying these relationships would be. And I think they're complex. There's going to be issues of intersectionality, as Piero has alluded to, Julia. Yeah, of course, there's going to be, of course, buffers as well that are really important to attribute to levels of risk. And I think the clearer the picture that we can get, the better understanding that we can have in getting in earlier treatments and more accessible treatments to the people who need them, and hopefully at younger ages, because that's my population, so that we can prevent this like lifelong trajectory of chronic pain. And that's really the goal of our work in Calgary. And hopefully with this new study that we have going that's larger and longer, we can get some of these, bigger details that our people are asking for.
Fantastic. Some really interesting work. And of course, good luck. And we can have you back on to share those insights and from both of you from any future work, of course. But thank you all for taking time to have a chat with us today and for answering the questions and for giving us your thoughts. I think we covered some really interesting topics. As I mentioned earlier, the webinar is recorded or was recorded, so everyone will be able to access the recording out of this session. And of course, others on the EFIC Academy Education Platform YouTube channel, you'll be able to find a link to those, and you can of course share within your communities. But thank you to our panelists today, and of course our really engaged audience for your presence and participation. That is all from us from now. We'll catch you on the next webinar. Have a fantastic rest of your day, and thank you again. See you soon.